Hi everyone, welcome to Sarcoma Foundation New Zealand's first webinar ever. I'm Andy Johnson. I'm the chair of the Board of Trustees for the charity. I'm going to give you a quick overview of the charity, and then I'll ask Joanna, who's also on the board, to introduce Carla, our speaker tonight, on the topic. So just very quickly, the charity was kind of started or officially recognised in May 2022 after about a year of setup, and with the specific aims of supporting patients and their families going through sarcoma or a sarcoma diagnosis in New Zealand, raising awareness of sarcoma in New Zealand, providing a website to support patients and their families with information that was New Zealand specific, to support research when we could, and to advocate with government and the health authority for better sarcoma services within New Zealand. So we did that very slowly over a couple of years. We raised some money by selling lanyards, and then we did Round the Bays almost 2 years ago now, and raised enough money to build the website, and it's just taken us about a year and a half to do that. So we're finally up and running with the website, and now we're trying to do some of the other goals that we've set ourselves for. So hopefully this is the first of a series of webinars, and Joanna will talk a little bit about that after the webinar. So without any further ado, I'll hand over to Joanna to introduce our speaker this evening. Thank you.
Thanks, Andy. So just welcome to the first webinar by Sarcoma Foundation New Zealand. These webinars are going to be part of a series, so we're really hoping it helps improve understanding. We recognise that many sarcomas are rare, so really taking the opportunity to kind of increase awareness and also improve understanding for anyone who wants to know a little bit more about sarcoma. So they're aimed at all, and everyone is welcome. The format of the webinar will be that we'll have a guest speaker, and then we'll have a Q&A section at the end and the opportunity for people to ask questions. So I'll just orientate people to the Q&A section, which for some people might be under the, there might be a Q&A box or with a speech bubble, or the three dots might open up the option for Q&As. So you're welcome to pop through questions throughout the presentation through there that I'll keep track of, and then we'll have a Q&A section at the end. Just a reminder, it is a public space, so just no personal details to go in those, but just keep the questions generic to protect people's privacy. So without further ado, I'm delighted to introduce Dr. Carla Pajak. She is an experienced sarcoma surgeon who is based in Auckland and has been pivotal for helping set up the Retroperitoneal sarcoma service in the North Island. So over to you, Carla. She's going to talk to us about retroperitoneal sarcoma. Thank you.
Thank you so much, Rhonda. I'll just start by sharing my screen, and then you can let me know. Can you see my slides?
I can, yeah.
Okay, perfect. So as Joanna said, I'm Carla Pajak. I'm one of the surgeons, sarcoma surgeons at Auckland City Hospital. I'm a general surgeon, so we're abdominal surgeons, and I've got a specialty interest in sarcoma surgery. So we're going to talk today about a little bit about just introducing the concept of the retroperitoneum, because it can be a little bit, if you've never heard about this before or don't have a background with anatomy, it can be a little bit difficult to understand. Then I'll talk a little bit about sarcomas more broadly, and then sarcomas that happen in the retroperitoneum. And then I'll just sort of take you through what a typical sarcoma journey can entail. So the abdomen itself has essentially two compartments. There's the, can you guys see my cursor as well if I'm moving around? So there's this anterior or more superficial compartment, and that is called the peritoneal compartment. And it has a lining, and you can see that the back of that lining forms the front of the lining of what's called the retroperitoneum, which is this space all in the back here. If we look at an abdomen, these are all the organs in the retroperitoneum, and the organs of the peritoneum have been sort of lifted away to help you see it. So liver, stomach, most of the small intestine, and the colon that goes from right and left has been removed here. And then if we take the colon away completely, we can see now the retroperitoneal compartment. The reason why it's important to understand this is because you can see that in order to access the retroperitoneum, you need to get through the peritoneum, so the front cavity. And that if you are trying to remove part of the retroperitoneum and you want to do it with keeping this lining intact, you occasionally need to take some other organs in order to do that. And so understanding how these all relate to each other helps understand the types of operations that we do in this part of the body. This is just put another way because it can be a little bit of a difficult concept. So the intraperitoneal organs are these ones in the front, and they are covered completely on all surfaces with this peritoneal lining. So that's these organs in here. The retroperitoneal organs are covered only partially with that lining, and so that's these organs in the D. It looks in these nice cartoon diagrams like there's not very much in the retroperitoneum, when in fact there is a lot. The way that we generally think about it in the case of sarcoma is we divide it up into right and left, and these are all of the contents of the right retroperitoneum, and these are all of the contents of the left retroperitoneum. So there are a lot of very different organs in there. There are a lot of very different tissue types in there, and so there are a lot of different types of cancers that can happen in there. So that's the retroperitoneum. We'll talk now a little bit about sarcomas, and we'll start broadly. So a sarcoma is an umbrella term that refers to any cancer that arises in things like connective tissues. So that's bone and cartilage, soft tissues like fat, muscle, blood vessels. Because those tissues are anywhere in the body, these sarcomas can form anywhere in the body. Saying that you have a sarcoma, one of the analogies that I use is it's a little bit like saying you own a dog. You could have this dog on the left who's going to behave and interact very differently than this dog on the right. There is a huge amount of variation, both within the individual or amongst the types themselves, so bone and cartilage and that sort of thing, but also within the subtypes themselves, there could be a lot of variation. We can't go by size either. You might think that a smaller size would be a little bit less aggressive than some of the larger size tumors, but even the smaller ones, if you keep going with the analogy of a dog, can be, their size doesn't necessarily predict their aggression. Sarcomas are incredibly rare, particularly in the retroperitoneum. There are very few less than 1 per 100,000 inhabitant years. They make up around 1% of all adult cancers. For retroperitoneal sarcomas, there doesn't seem to be a strong gender predilection for most of them, so they can happen in men and women in roughly equal percentages. They tend to be diagnosed in your 50s, but they can happen at any age. In the retroperitoneum, it tends to be in adulthood. They're very heterogeneous, meaning they're very, very different. Sarcomas generally, there's actually more than now around 140 different subtypes that are recognized. And of these, retroperitoneal sarcomas make up about 10 to 15% of all sarcomas. We name them after their cell of origin, so where they started, or some other characteristics, usually what they look like under a microscope. They can have vastly different behaviors. In the retroperitoneum, so in that cavity that we were talking about, these are the most common types of sarcoma that we see. The first most common is what's called a dedifferentiated liposarcoma. So this term dedifferentiated can get a little bit confusing. A differentiated cell means that that cell has finished going along its pathway and has become a very, very specific cell type. So a skin cell, a muscle cell, a nerve cell, something like that. That is a differentiated cell. So a cell that has de-differentiated has essentially gone backwards and has mutated away from that very specific cell with a very particular look. So a well-differentiated liposarcoma is a sarcoma that arose in a fat cell. Lipo just means fat. And the degree of differentiation tells us how much it still looks like a normal fat cell versus how far it has mutated away. The majority of liposarcomas in the retroperitoneum, unfortunately, tend to be de-differentiated. Those are mutated a little bit away from a normal fat cell, and they have slightly different, more aggressive behavior than the slightly less common, well-differentiated liposarcomas. Because these tumors often are so big, 15 centimeters is the median size when they're diagnosed, the chance that you have a little island of de-differentiated cells in your well-differentiated tumor is very high. We would tend to refer to it, if there's any de-differentiated cells, we would call it a de-differentiated tumor, because it's really going to be these cells that are driving how it behaves. So those are the liposarcomas. Those are arising from fat cells. The next most common are sarcomas called leiomyosarcomas, and these are arising from smooth muscle cells. They tend to arise from blood vessels in the retroperitoneum. These we tend to grade. The next most common is actually the grab bag of others. So these are very, very rare, and it's a whole group of different diagnoses. After that, we have things like solitary fibrous tumors and a malignant peripheral nerve sheath tumor, which is actually a cancer that arises from the insulation around a nerve cell. So that's, broadly speaking, what the retroperitoneum is, a little bit about the sarcoma types that we tend to find in there. And so now I thought it would be helpful just to go through what we'd really like a sarcoma journey to look like now in Auckland or in the North Island in New Zealand. So we'll start with diagnosis. These tumors, because of where they are in the retroperitoneum, they're sitting behind a very compliant cavity. So all of the intestines are very soft and will easily be pushed out of the way. So they often grow very, very large before they cause any obvious symptoms. The symptoms they do cause, even when they are large and causing symptoms, are often very vague. They're nonspecific. I hear a lot from patients that they actually, looking back, once they get their diagnosis, realize that actually they've probably had grumbling symptoms for months, if not years. It's just that they're so vague and so changing so slowly, they're really hard to notice. People tend to complain a bit of bloating, sometimes abdominal pain. Depending on the size of it and what it's compressing, you may be feeling full quite early, eating small meals and not being able to have any more. There can be some associated weight loss with that. The abdominal girth can sometimes increase. And if it's in the pelvis and compressing some veins, you can sometimes get some swollen legs. Because these tumors are so rare, and they present with such vague symptoms, we also don't have a good screening test for them. For a screening test to be effective, it needs to be easily administered, it needs to have a low cost, and it needs to be really specific and able to diagnose a cancer in a very early stage. And unfortunately, no such tests exist for sarcomas. These diagnoses then are often what we call incidental. And what we mean by that is most of our sarcoma patients have a scan for another reason. And as a side note, their sarcoma can get picked up on that scan. Any scan that suggests or raises the possibility of a possible sarcoma really should be sent for review by expert radiologists and by our whole sarcoma team to have a good look. The next step, once you've had a scan that has suggested a possible sarcoma, is almost always a biopsy tissue is the issue with sarcoma, because we need to know exactly what cell type we're dealing with, because that guides everything we do for it, from the type of operation to the other types of treatments we might offer. Just to give you an example of this, these are 4 different CTs of 4 different lumps that look pretty similar. They're all very large. They're all within the retroperitoneum, but these are all very, very different tumors. So this one here is actually a lymphoma. So this tumor would be treated with chemotherapy alone, a very specific type of chemotherapy. This person does not need any surgery, and they're probably going to respond very, very well just to that alone. This is a malignant peripheral nerve sheath tumor. So this is a tumor arising from a nerve. So this is going to need a very different type of operation than this tumor here, which is a liposarcoma. And then this tumor is actually a different type of sarcoma, a Ewing's type sarcoma. And this we would treat with actually really intensive chemotherapy, and then surgery, and then more chemotherapy. So you can see, if you didn't biopsy these, you might end up doing the wrong intervention or offering the wrong treatment for these. And you really, really need to have a look at it under a microscope to know what the next steps are for patients. These are the 2 most common questions I get about biopsies. I get these both from patients and also from fellow physicians as well. The first question, is a biopsy safe? Yes, absolutely. Is there a risk of spreading the tumor? No, we don't think so. Part of this relates to how we do the biopsy. A lot of people worry that the tumor is sort of contained and we're in essence popping it with the biopsy, or that we might be spreading tumor cells around when we pull the tissue out. So this is actually the needle that we use to do a biopsy, and it's what's called a sheathed needle. So the radiologist introduces the needle. The needle then fires into the tumor, and it's got a little hollow bit where a piece of tumor falls into it, and then this sheath comes down to cover that up, and then the whole thing is pulled out, and this prevents any tumor from spilling. So is it safe? Absolutely. There is no procedure, though, that has no risks. And so if you or a loved one is having a biopsy, the person doing the biopsy will take you through the risks specific to that biopsy, and nothing is without risk, but we really do need that information. Is there a risk of spreading the tumor? Is the tumor going to seed along the tract from the needle? We haven't seen any evidence that that is a risk. There's at least 3, but 3 of the biggest studies that looked at this had between 300 and 500 patients. And when they looked back at them, all of them had biopsies. They found that the risk of spread was less than 1%. And they were being very, very generous with the cases that they said this might be a case where there's been a little bit of spread. So these are very, very safe. It's not going to spread the tumor, and it is incredibly valuable information. 87% of the time, the biopsy that we get reflects the results that we get when we remove the tumor. So we're able to get really accurate information in a really safe way with our biopsies. Oftentimes when people get a diagnosis of a sarcoma, it's a very isolating diagnosis. There can be a lot of questions. It's not like getting a diagnosis of, say, breast cancer, where 1 in 8 women will be affected by that in their lifetime. Most of us know someone who's had other more common types of cancers, but often for sarcoma, it can be the first time you and your loved ones have ever heard even that term. There are even some physicians who may have in their career not looked after a patient with sarcoma. So it can feel very daunting and very isolating. I can't recommend enough that you really rely on reliable sources, because it's very hard to interpret information about sarcomas, again, because there are so many different types. And so it's hard to know what information applies to you. Both of these websites are excellent sources of very reliable information that you can trust. And so I really recommend starting your sarcoma research in places like that. In the North Island of New Zealand, We now have a North Island-wide sarcoma service, so all new diagnoses of sarcoma should be referred to us. We're based at Auckland City Hospital. We formally started in June of 2024, so the service is really still in its infancy. We now have a dedicated clinical nurse specialist who is an amazing resource for our patients. Before that, you would often get a diagnosis, you might get a clinic appointment, and you're sort of in limbo. And now we have somebody who can contact you and just be a touch point between you and the service. We also have dedicated clinic times and dedicated theater times now. So once you've got a diagnosis, the next step is moving into treatment. The first thing we do before we start a treatment is we actually talk about all of these cases at a multidisciplinary meeting. So at that meeting, we have the pathologists who've been looking at the cancers under the microscope, who are experts in diagnosis. We have the radiologists, the medical oncologists, and the radiation oncologists, and then the surgeons as well. The reason why we do this is that treatment of these tumors is very, very complicated and variable, and sometimes we use a combination of these three things to treat them, and in different orders depending on the type. These can also be really tricky to diagnose. It's not always immediately obvious that you're dealing with a sarcoma. In one study, 22% of tumors that went into a multidisciplinary meeting got a change in their diagnosis following specialist review, and around 12% of those patients changed from being benign to malignant or from being malignant to benign. So it's really important that you get someone who's very used to looking at these very rare cells under a microscope. The other benefit is that these are very rare tumors, and so what we want to do with rare tumors is group them together so that we can study them. And so when we bring them all to our meeting, if anybody knows of any trials or research, then we can enroll patients in those. Treatment is very, very carefully planned, but for a lot of people with cancers in the with sarcomas in the retroperitoneum, surgery upfront is often the first thing that we offer. The most common type of sarcoma in the retroperitoneum is a liposarcoma, which we've talked about, arises from the fat cells. And this often requires us to remove multiple organs, even though those organs themselves, like the colon, haven't been necessarily invaded. It's more, if you think back to those pictures I was showing you, it's because we need to include them so that we include the whole lining to the retroperitoneum, and then it's intact so that we can get an intact tumor removed. Surgery needs very careful planning. It's often a lot of time reviewing with the surgeon and with the radiologist. The scans can never tell us the whole story. They can tell us that two structures are next to each other, but they can't always tell us their relationship to each other. Sarcomas don't respect surgical specialties, so they can often cross boundaries, and they can often require 2 or 3, sometimes even 4 different specialists to all come to the same operation in order to get that surgery done safely. We know that big, aggressive, what we call a complete compartmental resection, reduces the risk of recurrence in patients. These are the most common types of specialists. So general surgeons like myself, we often use vascular surgeons. They help us operate on the major blood vessels. They can help repair those or replace them as needed. Orthopedic surgeons can help us particularly in the pelvis. Plastic surgeons, a lot of the surgery that we do sometimes can be quite destructive, and we need a plastic surgeon to come and help do some reconstruction after. And urologists can help us with things like if we're needing to reconstruct a bladder. Radiation and chemotherapy do have a role, but it really depends on the type of surgery and on the type of cancer, and the timing of when they happen, before or after surgery, or not at all. Again, depends on the type of tumor and the type of surgery. So that's treatment. Recovery. I really think that recovery from a sarcoma treatment has 2 phases. There's the initial sort of post-operative recovery, and then there's the survivorship recovery. So if you've had your surgery with us here in Auckland, some of your or all of your recovery from that surgery might happen with us at Auckland City Hospital. Sometimes some people might choose to do the final bit of their convalescence once they're sort of out of the woods and we're sure that they're over any major complications or risk, you may want to recover at your local hospital where you're closer to whānau, you're closer to community supports and things like that. Nurses, physios, OT, dietitians, they're all part of the team that help our patients recover from these operations. It's a huge undertaking, and we need expertise from a lot of different fields to get our patients through recovery. Once you're into survivorship, then that really life becomes about surveillance, and that scans and tests that are happening at regular intervals. We know that the highest risk period for most sarcomas is within the first 2 years after surgery, but unfortunately that risk never goes away over the lifetime, and so we do recommend that we continue imaging indefinitely. The interval and the frequency that we need to do it might be able to be reduced over time, but we do need to continue doing them. The risk of recurrence is really variable. It depends on the cell type. It depends on the specifics within that cell type, what's happened with your surgery or surgical results, and whether you've had any other treatments. The main thing is to keep in contact with your team, and that's where our clinical nurse specialist has really been invaluable to try and keep track, because we're often having to liaise with other hospitals to make sure that screening is happening. Recurrence can happen in 2 ways. Either the tumor can come back in the same spot where it originally was, or sometimes it can spread to other parts of the body. The most common sites that we see sarcoma are in the lungs. Otherwise, we can sometimes see it in the liver and sometimes in the bones. When this happens, the journey starts again back at the beginning, where we start again with scans. We may need a biopsy, and we'd want to rediscuss it again at our meeting and have everybody there so that we can plan the best treatment. Recurrences can be managed with any combination of these 3 things. It just depends again on where and what is happening. So just to recap, the retroperitoneum, what is the retroperitoneum? It's a cavity deep within the abdomen. It contains a lot of different organs and different cell types, all of which are eligible to form a sarcoma. It sits and is covered by the lining of the more superficial compartment, and so we occasionally take organs that are sitting in that anterior compartment to help us get a retroperitoneal tumor out whole. Sarcomas are very, very rare, and they're very heterogeneous. They're very mixed. It depends on the cell type of origin, and even within the cell type, you get a lot of variation. Generally, people's diagnosis should prompt a referral to us at the North Island Sarcoma Service, and then we discuss and plan surgery and treatments from there. For the retroperitoneum, surgery is often the cornerstone of what we do, but we do sometimes include things like radiation and chemotherapy, but we plan that as a group. The recovery, really those 2 phases, and just making sure that we keep on top of surveillance and scans. And if you have concerns, there's things you're worried about, that you know where to go to get those addressed. Does anyone have any questions?
Thank you, Carla. That's amazing. Thank you for describing what is, of course, such a complex topic really eloquently. Please send through some of your questions. I'll kick off with some questions for Carla while people send them through. Just remember to send them through on the Q&A and not the chat if possible, so we can see those. So Carla, you mentioned that the symptoms of retroperitoneal sarcoma can be quite vague. They can present either incidentally or with very vague, non-specific symptoms. What do you think the key messages are for patients and GPs to support people in organising scans, or when to go to scans to help make a diagnosis? What do you think the key sort of messages are for patients or GPs to support them with this really difficult diagnosis?
I think remembering that it is a really challenging diagnosis, and if we just polled 100 patients, do you have any abdominal pain? Do you occasionally feel bloating? I think you'd get 100% of people endorsing at least some of those symptoms. And so it's really hard to say we should be scanning everyone with those symptoms, because we'll do hundreds of negative scans, and that's not helpful. But I think what is important is, if you're noticing a symptom in yourself, to take that seriously and to advocate for yourself. And sometimes I think these things can come to the surface and then they're minor and they're niggles, and you just sort of forget about them and you can lose track of them in life. So one thing that might be helpful is to write them down and to go to your GP and talk about them and say, this might be nothing, but I'm noticing this. Can we come up with a plan for it? And that might be, can we recheck in a few months? I'm going to make another appointment and we're going to check in and circle back to this and see how I'm going. And if you're having a symptom that's persisting or that's getting a little bit worse, it needs to be taken seriously, and you need to work with your GP to sort of start moving up the ladder of investigations. And you want to start looking at the more common things and then progress from there.
Thank you, Carla. I've got a question that says, can well-differentiated sarcomas change to dedifferentiated sarcomas?
Given enough time, there is a chance that they can change to them. If you have sort of a 40 to 50 centimeter well-differentiated tumor that you left for decades, you would potentially start to see some areas of dedifferentiation, but not all well-differentiated tumors will do that. Some of them will just sit and stay as well-differentiated for their lifetime.
Mm-hmm. And are recurrences consider something called a metastasis?
So a metastasis is defined as the same tumor, but that is separate from the original tumor. So some metastases are recurrences, but not all recurrences are metastases, if that makes sense. So if you have your tumor coming back in the same spot, we would call that a recurrence. But if your tumor has come back in another spot, we would call that a metastasis.
Mm. And go ahead.
Oh, sorry. You can sometimes also present with both, where you've got the original tumor and we can actually see some tumor elsewhere in the body.
Is a recurrence after 8 years considered rare?
It's less common, but it's not impossible. Unfortunately, the risk of recurrence never falls to zero. But if we were to graph the total number of recurrences, the majority of them happen within that first 2 years, and then the risk falls off, but that risk never goes away. So every year after your diagnosis, the risk is technically getting lower, but it's never getting to zero.
And I think there's a question regarding the nurse specialist. Who would have access to the nurse specialist? Is it patients on active treatment or follow-up? And I guess how do they get in contact if they need to?
So our nurse specialist is just coming into the program now, and so since she's started, all of our new patients will have access to her, and she's also working her way through all of our patients who are on surveillance and follow-up. So anybody already in the program or anybody coming to the program should be able to access her, and she's got quite a big job in front of her, tracking down all of our patients, some of whom are have moved through treatment and are just on surveillance now. And so she's slowly introducing herself to those patients as their scans are coming due.
Okay, that's brilliant. Thank you. Carla, you mentioned, of course, the retroperitoneal sarcomas are complex. Can any general surgeon operate on sarcomas, or is there a specialist kind of training program that that people need to undertake to become a retroperitoneal surgeon for sarcoma?
So we are really trying to concentrate all of the sarcoma surgeries so that they're happening at one place. That's for a number of reasons. Because these are very rare and because there's so many different types, it's a little bit of a nuanced surgical approach. So a well-trained general surgeon would be capable of doing that procedure, but it's around knowing which procedure to do when and how to adjust your procedure based on the biology of the tumor that you're dealing with. The other part of it is the team. These tumors often require more than one surgeon to do them, and they also require specialist nursing teams and anesthetic support as well. And so really it's about having that whole team. And the research, sorry, I don't know why I keep going dim. The research shows us that when you have a team that is what we call high volume, meaning doing a lot of these regularly, they start getting better results, as you might expect. And that is probably multifactorial. So they get used to doing these operations, they get used to working with each other, they get used to the different biology, and patients start having better outcomes. So that's the rationale for trying to focus them all in one place.
Okay. We've just got a couple more questions. When researching survival for liposarcoma, the internet search is showing a 5-year life expectancy. And I guess the question is about, is that correct for everybody? Or are there differences within that?
The internet is showing a what for a 5-year?
Liposarcoma survival.
So liposarcoma survival is going to be driven by sort of 3, maybe 4 things. The first is when I was talking about that differentiation, so where you are on that, whether you're well differentiated, those tend to be more indolent. Those almost never spread. A dedifferentiated tends to be a little bit more aggressive, and those have the ability to spread to other parts of the body. There are other types of liposarcoma as well, things called myxoid liposarcomas and pleomorphic or round cell liposarcomas as well. And those, again, will have slightly different behavior. So even talking about liposarcomas, if we group everybody with a liposarcoma together and say this is your 5-year survival, even that is a bit inaccurate because there will be people in there with very, very different behaving tumors. So it's the tumor type. The second is the type of surgery you've had. So if you've had a complete resection, surgery has gone very well and your team feels very confident that they've removed it all, that's very different than sometimes these can be unrecognized or inadvertently resected. That's going to have a different outcome. And then it's sort of past behavior tends to predict future behavior. So if you have a tumor with demonstrated stability over long periods of time, then that tends to predict that it's going to have future stability. And then depending on those different subtypes, some of them tend to respond better to other treatments like radiation or chemotherapy. So looking at somebody's 5-year survival, it's really hard to give a number for all liposarcomas because there's so much variation.
So that might be a question that if a person might have a more specific personal request about that, that could be directed to their surgeon or their doctor who understands those behaviors of specific to their tumor, perhaps more so than a general statistic.
Yeah. And it's really hard to apply sort of big picture stats because they don't take into account all of those little factors that might be relevant to individual patients.
Okay. Final 2 questions. With recurrences, is it usual to have more than one tumor at a time? And when would surgery be considered?
So recurrences, really these are really, really rare tumors, and then recurrences are rare again. So we don't have a lot of really robust research on this, and there is a lot of variation between people. It's not uncommon to have more than one site of recurrence. And sorry, what was the second part of the question?
So would you ever consider surgery if someone relapsed and maybe had one or two tumors, or when would you not consider surgery? Maybe if there was lots of tumors, for example.
Yeah, the decision to operate on a recurrent tumor is a really difficult one, and it's really individual. And so you need to look at a few things. So one of them is kind of the behavior of that recurrence. So if this is somebody sort of 5-6 years and they've got a little tiny recurrence that you've just noticed, and it's a single one, the recommendation at that stage would actually be just to pause and just have a look, maybe do a really short interval scan over 3 months and get a sense of how this is behaving. If it's sitting there not doing much, well, then you've got to weigh the risks of operating versus the risks of just watching a very small bit of disease that looks to be behaving in an indolent way. If somebody has multiple recurrences and maybe they're growing and you're thinking, this is something that we want to think about treating, then it comes down to, am I going to be able to effectively remove these and remove all of them? And what is going to be the impact of that operation on that person? So what's going to be, what organs or what am I going to have to remove in order to be able to do that effectively? It can be a little bit of luck. Unfortunately, if you get a recurrence in a spot that's really easily removable, or if you get a recurrence in a spot that's very, very difficult, very dangerous for us to try and remove, then that can change the approach too. So I know I sound like a little bit of a broken record, but again, there isn't really a blanket recommendation because everybody's case can be so unique. Those are just the tumor characteristics. Then you have to factor in the patient characteristics. Do you have any other medical conditions or anything else that might increase or alter your specific operative risk? And so those are all of the things that we need to take into consideration before we go ahead and do surgery. We would talk about that case at our multidisciplinary meeting and get an opinion also from medical oncologists and radiation oncologists on whether they think that any of their treatments might help facilitate either our surgery or might be more effective than a really risky, dangerous surgery.
Thank you, Colin. Final question. New Zealand is a small country. How does it keep up with the advances in retroperitoneal liposarcoma? Are there clinical trials or alternative option that this centre, I think they mean Auckland, is looking at?
Yeah, great question. Really one of the, we are a small country, but one of the advantages that we have is that the sarcoma community is also a small community that works really collaboratively. And the only way that we're ever going to advance the treatment of these tumors is with international collaboration. And so there are some really well-established multinational groups. There's one called TARPSIG, which is the Transatlantic Working Group for Retroperitoneal Sarcoma. And that involves a bunch of very big retroperitoneal sarcoma centers in Europe, the UK, North America, Australia, and New Zealand as well. And we all get together and try and pool our patients. If there's a big trial recruiting, then we get notified about that, look, we're looking for patients with these specifications. Sometimes it's even just tissue that they're wanting to have a look at for a trial. There's lots of different ways that we can get involved. And so because it is such a small community of we have such small groups of patients, we're really trying to put them all together so that we can advance. And I think a lot of our patients are really, really committed and wanting to advance it. And so most of our patients are happy to participate in those trials if we meet the criteria for them. We're also looking at joining databases, just so that we can start just pooling what's happening with our patients and our outcomes and that kind of thing. So there is a lot of collaboration.
Wonderful, thank you. So we'll just close the webinar now. Just a big thank you for everyone who attended tonight. Really happy to see the first webinar get off the ground, and a big thank you to our speaker, Carla Pajak, tonight. Just keep a lookout for there will be a second webinar in the first quarter of 2025 with a different topic, and we're going to run these usually quarterly throughout the year. So I hope you've enjoyed it. And just before we finish off, I just want to let you know we're formally announcing our fundraising event for 2025. It will be Round the Bays in Auckland, March the 2nd. We've got a tent and we'll be there. So just really hoping that for people that want to get involved, come meet us and come join in. I think we're going to have some fun and maybe a sausage sizzle. So watch this space, and good night, everyone. Thank you for joining.
Thanks, everyone. Thanks, Carla.
Thank you.
Thank you so much.